Thank you. Good morning. Thank you for those kind words. I'm glad you didn't give the dates because it kind of makes me feel ancient and stuff. And I appreciate, it's always wonderful to be at a place where you see the future right in front of you, and at least from the abstracts, it's going to be a bright future for all of you. This is a talk I gave as an eponymous lecture at the Hand Society, and since I thought it's pretty interesting, I thought I'd give it again here. So I beg your indulgence. But I'd really like to talk about innovation and innovators, and the question that I'll pose is, does it take really 10,000 hours? And really I'd like to look at what might be common themes for both of these. You know, innovation in surgery has a very rich tradition, and the interest and enthusiasm to innovate never greater. The combination of new ideas and hands-on applications is the central tenet of surgery and can explain the historical success of surgeons as innovators and the progress innovations have made it. You know, innovation is really in accord with our national characteristics and with being a doctor. We learn in medical school to be individualists. We learn to ask questions and solve problems, and so it's consistent with that. It extols the virtues of ingenuity and freedom, flexibility, and the willingness to question conventional wisdom. Those of you may not be familiar with these people, but all of these are two wide generations of hand surgeons who have, and upper extremity surgeons who have contributed substantially. President Obama, in his 2001 January State of the Union, used the word innovate or innovation 11 times. In their text, Ethical Guidelines for Innovation in Surgery, Drs. Rietzma and Marino, who have written widely on the subject, emphasize that new is hot and old is not. You know, our journals emphasize innovation, dedicate sections to innovation. Annual meetings now always advertise innovation in their marketing things. Even institutions like ours, when you get onto the website, that's the first thing you see is innovation. But it also goes into individual practices. This is a hand surgery practice that talked about innovations that they're doing from the point of view of even marketing. And we as surgeons are very quick to adopt to the latest innovations, influenced to some degree by reimbursement, quality of care, patient preference, or professional competition. Also, patient demands put pressure on surgeons to adapt the latest technology, stimulated by news media and the internet, playing a role in enhancing consumer demands with high-profile coverage of innovation. So what I'd like to do is try to establish the definition of innovations for you, the concepts of innovations as they apply to surgery, particularly in the upper limb. We'll look at some of the common threads found in innovators, as well as potential obstacles to innovation. I'll touch on the fact that probably innovation needs more rigorous testing, adherence to the criteria of evidence-based surgery, and subject to expanding regulation, especially when related to our industrial partners. And we'll also look at what might be the impact of our restrictions in training, increased workload, and the emphasis on the importance of leisure time on those of you who are our potential innovators. Actually, innovation is one of the biggest buzzwords around the globe, as researchers, business gurus, governments are all trying to figure out what it is. Over the past decade, the concepts and principles of innovation have largely been defined through research and publication in the business world. I don't know anything about business, okay? My father manufactured ventriloquist dolls, and he told me, stay away from business. And he said the only thing that he couldn't make a living from clever people, he made it from dummies. But in broad terms, innovation could be defined as the act of introducing something new or the use of a new idea or method. In some instances, it's used synonymously with invention, although innovation is more precisely defined as something thought up or mentally fabricated. As might apply to our specialty, the term enabling technology innovation refers to an innovation which supports further developments in the field. The operating microscope, for example, it supported countless advances in superior management of complex wounds, replantation, sophisticated reconstructive procedures, and you all see that and you all think, accept that this is the standard of care now. And we saw a meteoric growth in the field. Harry Bunke was one of the early ones from San Francisco area, and replanting a kid's hand now is just an accepted fact. And we've seen reconstructive things. Chun Wei in Taiwan did a wraparound flaps. Jim May, total thumb, toe to hand. And Urbaniak and Weiland with vascularized bone transfers have influenced all of us, based in part on the ability of the microscope. And we see in nerve surgery, in brachial plexus work, and peripheral nerve surgery, the concepts of nerve transfer has changed the whole pattern of the management of these problems. Another example, and we'll hear in the first paper, I think, on locking screws. And these were developed actually for maxillofacial work, first in Switzerland. And it was an integral part of the first distal radius system that AO made, which was the pie plate system. And while we attribute a lot to American innovators on this, actually it was used quite a bit for dorsally displaced fractures from the volar approach. And Heini Winker in Erfurt, Germany had a series in 1998 of tremendous success with this pie plate put on the volar surface. But in North America, certainly in the English publications, Orbe in Florida really advanced innovation with a more anatomically designed implant as well as innovative surgical approaches. And we could also turn his development as an example of sustaining innovation. And this became what relatively has become worldwide as a standard of care. And the fact that this was so rapidly adopted reflects the probability and observability of a successful innovation. That is, the more observable the benefit and the absence of risk will influence the more rapidly this will happen. Technology changes can be viewed as disruptive if the innovation threatens changes to our industry or our surgical leaders. The concept of stable internal fixation for both simple and complex hand fractures was brought to us by colleagues from Switzerland also, but met with incredible negativity, just like the AO when it first came to North America. Very negative suspicion, despite seeing the remarkable results that we saw from these individuals. Richard Smith, who was in Boston, a hand surgeon that I worked under as a resident, he, with some trepidation, sponsored a course for the American Society of Surgery of the Hand in Vail on this, and upwards of 40% of the attendees were very senior hand surgeons who frankly didn't believe this, and they came to see for themselves. But they also realized that in order to stay preeminent in the field, they had to at least be familiar with this. And even early presentations to the American Society of Surgery of the Hand and other societies focused on the complications of this, and there was skepticism continued. In the maxillofacial world, Paul Manson, who was president of the AO Foundation, introduced a lot of this and was met with tremendous resistance to plate and screws. But on these pan-facial fractures from, you know, airbags and the motor vehicle. He was preeminent in fixing all of these and giving you a much different outcome per se. And I'll discuss him later as an example of a true innovator. Well, surgery requires daily assessment, decision analysis, and frequent development of new approaches. Therefore, perhaps we can categorize surgical innovation from a different perspective that all of you as surgeons may find more familiar. It can be a novel procedure. We'll hear a paper about the hook of the hemihamate graft, and Hill Hastings introduced this, and I'll spotlight Hill shortly. It can also be a modification of a standard technique. During his fellowship with me, Neil Jones, we had so many multi-digital replants that he said, well, why don't we put a Y-shaped vein graft on the fingers before we attach them? And therefore, we only need to make one anastomosis in the arch here rather than in the fingers there. And this proved to expedite the procedure and get a more robust arterial inflow and better outcomes. A third categorization might be a new indication for established technique. We're seeing interest in cubital tunnel surgery being done endoscopically. Another is perhaps you can categorize one as the combination of an established technique with another modality that might be used for the first time. This is a woman I saw from Morocco who probably had an infection as a child, and she presented like that. So we call this a 7-iron. And we combined Ilizarov with a standard plating as we got this out to length and had a nice functional result combining these two procedures. And finally, a novel application for an established technology or an established implant. This is a woman who had an unstable elbow location and with multiple medical problems, and a colleague of mine, this was actually a case report in this month's Journal of Hand Surgery. Instead of putting an external fixator, put an internal fixator, and then took the plate off at 3 months, and this was her result. So this is another type of innovation. Well, what might be some of the common threads that we see in innovators? Given that surgeons, each and every one of us, continuously faced with situational challenges, what are these common threads? Are they just gifted individuals, or have they produced their innovation as a result of putting in 10,000 hours of experience? The concept of the gifted individual dates back to the Greek literature, and statements like, on the whole, the gods do not bestow more than one gift on a person. This continued, if you look at the literature, it continued all the way into the 20th century. And this is John Stuart Mill, who was an extraordinary guy. And he said it's a common tendency among mankind to consider all power which is not visibly the effect of practice, all skill which is not capable of being reduced to mechanical rules as a result of a particular gift. He was a unique individual. He mastered Greek at age 3, Latin soon after, logic and mathematics at age 12, but had a nervous breakdown at age 20. A different perspective was probably our American great innovator, Thomas Edison, who said genius is 1% inspiration and 99% perspiration. Well, contemporary investigators such as K. Anders Ericsson, is a psychologist, and Malcolm Gladwell, many of you probably have read some of his books, have proposed an alternative concept which Ericsson described as deliberate practice, and identified the so-called requirement arbitrarily of 10,000 hours of experience to become expert. Gladwell, in his book Outliers, gives many examples, one of which was the Beatles, and the fact that the Beatles started to play as a group in this sleazy nightclub in Hamburg, and they played 6 to 8 hours a day to get their theme and probably was what made their particular brand of music so successful. And it's been applied for many other fields, such as chess masters with similar observations. Neurologist Daniel Levitin at Yale, he pointed out that it seems to take the brain this long to assimilate all that's needed to achieve true mastery. But maybe there's another way of looking at it. William Dugan, a professor at Columbia, writing in several texts, has put forth some fascinating insight into the characteristics of an innovator, which he also describes as strategic innovation. And remember, much of this literature on innovation comes from the business world. He felt that some of this may be found in the writings of a Prussian general and military historian, Karl von Clausewitz, who in 1832 he published his classic military text on the war. He analyzed Napoleon Bonaparte, this is von Clausewitz, and the extraordinary military accomplishments of this young general. And he believed that, von Clausewitz, that there are 4 steps associated with his success, or the strategic intuition, or the innovative military accomplishments. And one is intelligent memory, is that you need past experience, and this we can allude to this so-called 10,000 hours. And then you have to clear your mind. You have to be willing to say, there's got to be a better way. You know, I know this is the way I was taught, this is the way we do things, but maybe there's a better way. So you have to be able to, it seems like, in these common threads, to think out of the box, so to speak. And sometimes it requires a flash of insight. He describes coup d'oeil, or the strike of an eye, that just something hits you. And then, most importantly, resolution. Not only understanding what to do, but being committed to work at getting it done. And the example he used was Napoleon's impact on the success of expelling the British from a southern port in France. That was, at that time, France's most important naval port. And the story goes that, fresh out of military school, Napoleon objected to the commander's idea of doing a frontal assault. He said, after thinking about it, he said, no, I think we should go up above, take some forts above, and then shoot cannons down. Well, the frontal assault failed, and then they followed Napoleon's idea, and it worked. But Napoleon was already a keen student of military history, and his recommendation may well have been based on intelligent memory. He was aware of the American Revolutionary War and the success in Boston of Henry Knox, whose idea was to drag cannon up to the hills of Dorchester Heights and shoot cannonballs on the British fleet, and they took off. And he also was familiar with Joan of Arc and the Siege of Orleans, where she did exactly the same thing. Instead of a frontal assault, taking some forts on high. So Napoleon's flash of insight came not from direct experience, but based upon intelligent memory, and he had the resolve to stand his ground, even as a young commander. So given that we as surgeons, throughout the world, if you travel the world, you're always impressed with how surgeons will tend to solve problems with new or innovative ways. I can't highlight all surgical innovations, but I've chosen 4 individuals who I know very well. And, oh, sorry, go back one. Yeah. And I've worked with, oh, forget it, I've worked with these people in one way or another, and I think they all perhaps reflect these principles of von Clausewitz. Hill Hastings, and Paige will know that's in Telluride. He experienced, like many of us, very unpredictable results with a variety of surgical options for PIP, fracture dislocations, and we'll hear a paper on that this morning. And what he did is go to the lab and try to figure out the anatomy, try to figure out what makes instability, and confirmed the need for a stable buttress in order to prevent subluxation. And with some fellows, Capo and Steinberg, they continued to go and search for a reasonable alternative as a bone graft, an osteoarticular graft, and came up with the hemihamate buttress. And ultimately, this has received enthusiastic support by others who have tried it, and it's a major innovation for a very difficult problem. Your future partner, Bob Medoff in Hawaii. Many of us are aware of Bob Medoff's work on the distal radius and the concept of so-called fragment-specific fixation of fractures and innovative implants that he developed to handle these problems. When we looked at these, people said that, well, that's just pins and staples, and yet he showed by strategically placing these, they were just as effective as larger implants. But many of us may not be aware that he first started with hip fractures, and he had problems with different forms of femoral neck and intertrochanteric fractures with standard implants. And he tried to do work at the University of Hawaii in the biomechanical lab, but he couldn't get access there. And so with the help of a handyman working on his home, he brought home some cadavers and they created prototypes, and he developed a homemade testing device in his living room, and he developed different implants. And he spent a lot of time on his own developing the testing things, and ultimately he developed a different form of an implant and actually started a company, the TriMed company. And this was all by this so-called resolve. Lee Osterman, a colleague of ours, really brought into the wrist area the era of arthroscopy. And he showed how we could deal with ganglia arthroscopically, with ulnar-sided lesions, ligament, triangle fiber cartilage, and even distal radius fractures, as well as arthroscopy treatment of CMC arthritis and what have you. But he also pursued a very difficult problem, and that's the Essex-Lopresti axial loading injury. And here too, he and his colleagues went and worked on a variety of options, and he came up with a very good means of reconstructing the interosseous ligament and using first allografts and then native tissue. And he probably has the largest series in the world with this. My final example is Paul Manson, who I mentioned. He was head of plastic surgery at Johns Hopkins, just stepped down, retired. And what he came up with, when he graduated, he actually wanted to do his plastic training at Hopkins. He wanted to be a cosmetic surgery, plastic surgeon. He was looking around for jobs, and so he moonlighted at the shock trauma center in Baltimore. And he started to see these complex facial trauma. And in those days, they treated them with wires and external wires, and the results were things like this. And so Paul said, you know, he's got to do better than this. And so what he started to do is analyze these pan-face fractures and come up with better incisions that were extensile but aesthetic. He developed implants to fix these, and even microvascular tissue transfer, and started doing these immediately. And he was brought before the surgical board by his colleagues, and they wanted to fire him. And he was doing radical stuff, and it was unacceptable. He stood his ground, and the chief of surgery there was the only one who defended him, and ultimately he was able to establish a worldwide new standard of care. But he had the resolve to stick with that. Now, this is a 16-year-old. These are his cases. It's hard to see, but she's got plates on every bone in the face. And this is a follow-up and at graduation. So the impact obviously was substantial, but it wasn't overnight, and it required a good deal of resolve. But he's an example of thinking out of the box, coming up with new things, pursuing it with a good deal of resolve. Well, now we look at ethics and regulations. Many new surgical treatments or implants have been developed after biomechanical testing, but unfortunately all too few are subject to rigorous evaluations of safety and effectiveness that's applied to most non-surgical treatments. You know, the perception of surgeons and patients of a quicker recovery can lead to rapid acceptance of a novel approach of new technology. There's really no FDA as yet for surgical innovation. And regrettably, as we see with metal-on-metal hips and with things like thermal capsulorrhaphy, there are lots of examples of this in our field. And thermal capsulorrhaphy is probably a good idea that it seemed when it came out, but subsequently it's been a big problem. And if you look at some of the early papers encouraging things, and as people did more, found nerve problems, shoulder stiffness, and worst case scenario is this is a young college athlete who had complete head necrosis from the thermal capsulorrhaphy. D'Alessandro and the colleagues reported their experience, and basically enthusiasm for thermal capsulorrhaphy should be tempered until further studies document efficacy. But just think of how many people and how many shoulders were traumatized by this. We're seeing it in the wrist too. And whether or not this is going to prove to be the same, it's hard to know. But in this couple of articles, that basically evidence is not here. Yet surgeons pick up the new technology, go with it, and it's only when repeated reports come out that this becomes a problem. Scott is a urologist, and in the British Medical Journal in 2001 made an article identifying Scott's parabola, and basically subtitled "The Rise and Fall of New Technology." A promising idea, possibly starts as a research tool, but then encouraging reports, and all of a sudden widespread enthusiasm. And publications, and in the lay press, internet, and it becomes a standard by many surgeons. Until doubts creep in, damaging survey reports, medical legal cases, and now the same authorities that were promoting it condemn it. And the operating staff wonders why we have all these different instruments and what have you. And then the senior surgeons tell all the junior people, oh yeah, in my day we didn't have to do this, and that was ridiculous. You know, things like that. So that's Scott's parabola. And it's not surprising that the development and implant of new technologies have played a consistent and central role throughout the history of medical malpractice. Peter Jacobson is an author who has written quite a bit, and one article entitled "The Medical Liability of Technology," he noted that if you look historically at American medicine, malpractice liability has been really a struggle between technological advances and injuries resulting when these fail. We still see an increasing emphasis on technology and innovation, describing new procedures to newspapers and the internet before they are formally tested. This really makes the need for more thoughtful dialogue from all of us about what constitutes human research and how to protect patients' rights even more pressing now. Richard Gelberman is now in St. Louis, and colleagues in JBJS 2010 highlighted the threat to scientific integrity and public trust associated with the complex relationships between orthopedic surgeons and the medical device industry. Dwight Eisenhower, who was a famous general and then president in the 1950s, in one of his final speeches talked about the military-industrial complex. But there really is a medical-industrial complex, and it seeps through everything we do in a very insidious way. Furthermore, how does this growing enthusiasm for surgical innovation adhere to the principles of the Belmont Report, which was produced in 1979 as the seminal document regarding research ethics? In the document, it's acknowledged that innovative practices have attributes of both practice and research, but it states that radically new procedures should prompt formal evaluations of safety and efficacies, and that these new surgical things are not necessarily in the category of research. In a symposium in the JBJS 2011, David Llewellyn from Mayo Clinic stated, "It's easy to argue that as a society, we need rules in the knife fight of medicine to protect our patients and ultimately our profession. Our patients cannot and should not be made to bear the judging between medical treatment options with regard to their efficacy and safety when most of us as physicians are not qualified to do so out of our narrow area of expertise." Michael Gross, writing in the British JBJS, proposed a phased clinical trial, first a laboratory study if you have a new innovation, and a strictly controlled cohort investigation, then a randomized controlled study, and finally surveillance. And this is the critical part. This is where registries are coming into discussion. The Hospital for Sick Children has proposed a 10-step way of introducing new technology that surgeons have to fulfill all these 10 steps, but importantly, plans for collecting and surveillance data. So let me finally return to the future and obstacles, and to Erickson's concepts of deliberate practice or 10,000 hours, and how it may or may not become a factor in the evolution of surgical innovators among you. Certainly, we can't expect someone who's just completed an upper extremity fellowship, be it 1 or 2 years, to have developed sufficient memory to fulfill that aspect of it. Rather, it may be what lies before individuals that prove to be the obstacles that may change. We may find ourselves employed by medical consortia with fixed hours of work. Surgeons will be under increasing pressure to achieve a positive economic report card. For some, workload may increase with decreasing reimbursement. For others, extra time traditionally dedicated to teaching, research, and perhaps innovation will be in competition with lifestyle interests. What will be the future? The warning of Sir John Erickson, surgeon to Queen Victoria, regarding the limitations of a knife, will this be the case? Perhaps, because we may be faced with massive technological changes. There may be unprecedented opportunities for a surgical innovator. There'll be rapid advances in imaging, minimally invasive techniques, gene therapy, cell-based mediation. Though we may be at the threshold of an entirely new era, and it may involve surgical innovation based upon new technologies. So I'll close with a quote of Peter Drucker. He was one of the best known and most influential thinker and leader on management theory, again back in the business world. He said, "In innovation, as in other work, there's talent, there's ingenuity, there's predisposition, but when all else is said and done, innovation becomes hard, focused, purposeful work, making very great demands on diligence, on persistence, and on commitment. If these are lacking, no amount of talent, ingenuity, or knowledge will avail." And for those of you who have not yet completed your 10,000 hours, I think it's well worth it. And I think if you have the opportunity to pursue an idea and to do something creative, you will not only enhance your own life, but obviously enhance your specialty and enhance patients. And I thank you for this opportunity.
So Jesse, can I ask you a question?
Yeah.
So just doing some quick math, 10,000 hours. What is 10,000 hours of residency? When do you complete 10,000 hours of residency? And in an 80-hour work week. In an 80-hour work week. When do you think that is?
2.5 years.
Yeah, 4 years. In your 4th year, you finally go over the test. So, and then you do your hand fellowship, and there's another 10,000 pounds.
Depends which fellowship. Well, it's true that you know, it's almost a euphemism when we talk about it, that there's a lot more to it than simply time put in, and one has to have motivation, I think, as much as anything else to do this. And so there are a lot of obstacles that more and more we face. People who want to, you know, work just in a health plan that has 40 hours a week and that's it. There's nothing wrong with that, but it certainly is an obstacle to, you know, being more creative and things like that.
Any other questions? And just one final question. So do you view, in looking back at residency education, do you view the present work restrictions as a detriment to the training of our residents?
That's an impossible question. Let me say this. What do you do? No, I think I think there are other problems in training than just the hours. For example, we're so much more efficient now in doing the things we do than when I was a resident, you know. So if you talk about surgical exposure to operative procedures, there's so much that can be done within the day that we never could do. At the same token, there's such an emphasis on reimbursement and economics that and legal and all of this that we can't allow residents to operate independently. You know, in the days when I was a resident and we had 6 months where we were chief resident, but we were the doctor. There wasn't an attending, but we were the attending. We were given attending privileges. And we ran a big service, and I think generally the chief residents did a good job because we were so scared. You know, we were very compulsive and things like that. But that experience is probably very hard to duplicate today. Whether surgical trainers will be coming in more and more, something like that. The thing that I am most concerned about, being now a senior citizen, is learning how to examine and interview patients. And that's something I see emphasized less and less, okay? If you're talented and you're thoughtful, you'll be able to be a good surgeon. But if you don't develop those skills and those practices during your training, it's very hard when all the pressures to produce and move people along come into play. So that's what I see. It's old-fashioned, but I think, you know, you still need to figure out how to solve the problems as best as possible by, you know, in one-to-one relationship with patients. But that may change too. You may, I could tell you a dirty joke, but you may end up giving a specimen to a machine and that'll tell you everything, you know, and stuff like that. So it's hard, I can't answer the question. And I'm glad I don't have to.